All right, so good. Hello, everybody, and welcome to our speaker series today on October 14th. We have a very interesting topic, updates on food allergy prevention and early introduction of foods with Dr. Amanda Cox and Ali Doppelt. And today's activity is approved to 1.0 contact hours of continuing education by the American Association of Nurse Practitioners. This activity was planned in accordance with AANP accreditation standards and policies. I just want to quickly give us introductions for our amazing speakers today. So Dr. Amanda Cox is an assistant professor of pediatrics, and she is a fellow of the American Academy of Allergy, Asthma, and Immunology. She received her BA from Columbia University and her medical degree from Albert Einstein College of Medicine in the Bronx. She completed her pediatrics residency and fellowship in allergy and immunology at the North Shore, Long Island Jewish Medical Center, today known as Northwell. She joined Mount Sinai Division of Pediatric Allergy in 2008 and again in 2016 after working for 2 years in private practice in Brooklyn. Through her career, Dr. Cox has been involved in specialized clinical care in the field of food allergy. Ali DePelt is our member here with Food Allergy Nursing Association and is also an allergy nurse at the Jaffe Food Allergy Institute at Mount Sinai, where she specializes in food challenges and oral immunotherapy for pediatric patients. She holds a baccalaureate degree in public health from Tulane University and BS in nursing from Massachusetts General Hospital Institute of Health Professions. Currently, she's pursuing a psychiatric mental health nurse practitioner's degree at Pace University. Congratulations, Ali. And today's learning objectives, I will let you guys take over the screen and share now. And that should now be available for you guys to share.
Okay. Did it work? Let me know if you see it.
Yes. Okay, so we're going to talk about updates in food allergy prevention and treatment today.
So yeah, we added a little treatment information too. I think that you had requested it, so we added that on as well.
Thank
So
you
we'll
so
see
much.
what we get through because a lot of slides. Okay, so
Um,
I'll
can you advance?
advance.
Yes,
Okay,
please. Thank you.
so this just our disclosures. Okay.
Okay, so today we're going to review updates in food allergy prevention. We're going to explain current recommendations for early introduction and then summarize available and emerging treatments. And we're going to focus specifically on nursing roles in family education and allergy management, given the updates in prevention and treatment. Next slide. Thank you. Okay, why food allergy matters, we all know, but just, to remind us, 1 in 3 children in the US have a food allergy. This creates a major impact on quality of life for patients and their parents. But now we do have some evidence about ways to prevent food allergy in some cases. We know that results from some studies have shown delayed introduction and strict avoidance do not prevent food allergy, and that earlier introduction for some specific foods may be beneficial. So all of the guidance that we give our patients, whether it's in a food challenge or a follow-up visit, should reflect these updated changes. And then we're also going to talk about emerging therapies for food allergy. It's great that we have a lot of new options for patients compared to even just a few years ago. But that it does also mean that we need to have really good shared decision making with patients and families because the new options that we have are not one size fits all. So we really have to individualize treatment for each patient and family.
Okay, should I take it from this point now? Okay, great. So we thought we'd sort of summarize some of the like salient prevention studies and sort of how those have led to changes in guidance for patients. So that will be my role here. So, the question is, can we prevent food allergy? And a lot of different things have been looked at and there are ideas and studies that are still sort of ongoing, and a lot of places where we don't know for sure. We've been looking at the mode of birth or delivery. There's some evidence that babies born by C-section have a higher rate of atopy or allergic conditions compared to those born vaginally. And there are studies looking at interventions that might mimic the vaginal delivery microbiome exposure for patients that are, for babies born by C-section. There's definitely questions about breastfeeding, whether exclusive breastfeeding or combination with formula, and the duration of breastfeeding, whether this might have an impact on food allergy prevention. The maternal diet during pregnancy has been looked at and still being looked at. The selection of formula, probably is a big is a big thing, and people have always are always asking, what if we can't give our baby, for instance, milk? Do we give hypoallergenic? Do we give elemental formula? Do we need to do goat's milk formula now, or all these new ones that are available? So formula selection is something also that we have questions about. Probiotics, both for infants as well as pregnant moms, and even young children is a question of whether that might be helpful. The microbiome itself, which is a giant category of information and study. Eczema and skincare, so whether just aggressively treating eczema or aggressively treating dry skin might prevent, in addition to preventing eczema, may it also prevent food allergy. And then I put in red the timing of complementary food introduction, because that's sort of like the most detail that we're going to go into, and where we have sort of the most new evidence that's also led to changes in guidelines. I think I would say all of these other areas, in terms like, I don't want to give away the conclusion, but in terms of prevention of food allergy in particular, these other modalities haven't really shown anything that's conclusive, whereas complementary food introduction, in particular timing, we do have new, at this point it's not that new, but some information about that. So I start with the LEAP study, which hopefully everybody here has heard about and is familiar with, but just as like a quick review, the LEAP Learning Early About Peanut Allergy trial was a landmark study. The idea of this was to look at whether introducing peanut early to infants, particularly those who were high risk for allergies, so meaning they had egg allergy or moderate to severe eczema, if introducing peanut might actually prevent the development of peanut allergy. And so high risk patients were defined this way, based on skin testing size to egg or history of egg reaction. And severe eczema was considered that which needed the topical steroids or calcineurin inhibitors to manage, or had a high SCORAD. So in this trial, infants who were considered high risk were randomized to either avoid peanut for the first year of life, or be randomized into group to start introducing peanut early. And the idea was to look and see if the patients who had, looking at these two different groups who had a peanut allergy by 5 years of age. And these are sort of bar graphs that just show the reduction in peanut allergy in the group. So if you look on the left side, the avoidance group versus the consumption group, 17, there was an 81% relative reduction in the presence of peanut allergy. If you're looking at people with negative and positive peanut skin tests when they were starting the study, and if you look at the skin testing, the peanut skin test negative and positive, you also see similar improvements. The group that was consuming peanut from infancy had a lot less peanut allergy at 5 years of age. So this landmark study demonstrated that early peanut introduction, the first 11 months of life, significantly reduced peanut allergy prevalence by 5 years of age. And this was a study that took place in England. So infants at high risk, peanut, again, they were started from between 4 to 11 months. They were eating, I think, 2 grams of peanut a week. And and they had decreased peanut allergy by age 5. So this taught us to introduce peanut early, keep it in the diet, and to discuss peanut introduction at the 4 to 6 month visit for infants. So that's sort of like a lot of work sort of bundled into a very quick summary. But the idea is I wanted to kind of go through the important information for different foods that we've seen. So peanut definitely has the strongest data for it, and we'll talk about it a little bit later. But their guidelines have been revised as a result of those findings. So for other foods, we can look at individual studies. I thought I'd just present this, which was like a meta-analysis of different egg introduction studies, and what they found in this sort of this meta-analysis, that no study provided conclusive evidence of early egg introduction preventing egg allergy, and they couldn't come to any guideline for timing egg introduction. They looked at 416 articles. There were 6 randomized controlled trials, and including over 3,000 patients. And they found a very low to moderate level of evidence from all this data for a benefit to early egg introduction. And there was a subgroup analysis. I looked at high versus low dose egg, and there was some indication that consuming less than 4 grams a week had a greater preventive effect than higher doses of eggs. So this is interesting. This is the same study, but just looking at the sort of graph of the evidence of sort of taken from the different trials that they looked at. What they said was this was low to moderate level of evidence. The study populations were very heterogeneous, so it's hard. One of the challenges of meta-analyses is the studies are not always very similar, and even the patients included are not very similar, and the techniques and the interventions are not always similar. There was varying amounts of egg protein that was introduced to these patients, and they all measured different outcomes. Some measured actually clinical egg allergy, which would be, evidence of reacting to egg, and some measured egg sensitization, which, as we know, doesn't always mean that you're allergic to egg. And egg sensitization would be either by a positive skin test or an IgE level to egg. But they did decide that there was no indication to hold allergenic foods beyond 4 to 6 months. But also, we need more data on early infant introduction of egg before we can adopt this as a full-scale guideline for preventing egg allergy. Milk is also there's a lot of interest in milk. Milk and egg, as you know, are sort of our most common food allergies in infancy and in toddlers. So there's certainly interest in prevention of cow's milk, but the data isn't conclusive for this at all. So this just sort of summarizes a few studies looking at early introduction of milk. And the first one from Japan, this showed that small amounts of cow's milk formula, around 10 cc's between 1 to 2 months of age, may prevent development of milk allergy. But another study also showed a protective effect, but other studies did not find that early milk introduction was preventative of milk allergy in particular. So based on sort of these studies, I know this is just a few things from milk and egg, but from the evidence that we have, there may be a lower risk of egg allergy if we introduce cooked egg from 4 to 6 months. It's not solid and very high level evidence, but there may be an improvement. Regular milk exposure in infancy might help tolerance. And we do want to avoid brief or single exposures to milk without incorporating it. But all this evidence is still evolving. However, the trend, I think, is showing that early and consistent feeding of complementary and allergenic foods is beneficial, but we'll see. This was another trial that was also the group that did the LEAP study was involved in this one as well. And this was looking at not just peanut introduction, but introduction of 6 different highly allergenic foods to infants between 3 to 6 months of age to see if it would prevent the development of all of these food allergies. So in this early introduction group, there are over 500 patients, and this group was instructed to continue breastfeeding and between 3 to 6 months of age, introduce milk, peanut, egg, sesame, cod, and wheat. And these are all in infant safe forms, and to have 2 grams of protein total twice a week. And then the standard introduction group continued to breastfeed and did not have any of these allergens introduced until 6 months of age. And the idea was to look and see if food allergies emerged in these two groups. And after 6 months, there was no restriction on introduction. And the primary outcome of the study was to look at food allergy to one of the 6 foods between 1 and 3 years of age. And what the study was, their adherence was not great in the study. Looking at the intention to treat, it did look like there was a trend towards early introduction decreasing the prevalence of allergy in that group. However, you can see from the p-value above, it was not significant. For those who did strictly adhere to the regimen, for egg, they did see that early introduction resulted in decreased egg allergy. And although they did find that the adherence to egg was the lowest, however, introduction in this study did show an improvement. Their conclusion from this was that early introduction of egg white protein was a safe approach and associated with a significantly lower prevalence of egg allergy. I did not show the data for peanut, but they found similar results for peanut compared to the LEAP study. If they were looking at overall foods, the early introduction group did show improvement and decreased prevalence of food allergy for those who really did follow the regimen, but it was not significant in the intention to treat analysis, which would have included people who did and didn't totally follow the regimen. And there was a very high rate of non-adherence, and that's because this was very hard to do. If you can imagine all 6 of those foods for the 3 to 6 month old age range. And they did find that there were no significant benefits specifically for the early introduction of milk, sesame, fish, or wheat in this study. Another study that's also interesting in that it's looking at both the introduction of the allergenic foods to infants, but also in combination with regular application of skin emollients starting at 3 months to see if this combination could decrease the risk of food allergy in childhood. And this was a Scandinavian study. There were over 2,000 infants born at 3 hospitals. They were randomized into either no intervention, 2 just skin intervention, 3 just food intervention, or 4 combined skin and food intervention. And the skin intervention included an emollient application 4 times a week from 2 weeks of age. The food intervention involved the complementary feeding of allergenic foods, including peanut, milk, wheat, and eggs, starting at 3 to 4 months of age and fed 4 times a week or more. These infants were followed until 3 years of age, and the outcome they were interested in was the allergy to any of these 4 foods at 3 years of age. And what they found that if you're looking, this is the risk difference for intervention versus no intervention. So the exposure to commonly allergenic foods between 3 to 4 months of age, complementing to regular feeding, reduced the food allergy at 36 months, in particular reduced peanut allergy at 36 months. And you can see peanut allergy is actually significant. Emollient application did not prevent food allergy and did not actually prevent atopic dermatitis. And they didn't find any safety concerns with any of these interventions. So based on this, the conclusions were that early introduction of common allergenic foods is a safe and effective strategy to prevent food allergy, especially for peanut. And their other take-home point was that families should keep the food in the diet once it is introduced. Should I do this to Allie too? I don't know if I could, I'll keep going. So from these, the EAT study and the Prevent et al. Study, the takeaways that we take from this are that early introduction of multiple allergenic foods is safe. They do seem to reduce peanut and egg allergy rates. Emollients are not effective to prevent eczema or food allergies. So sort of our message for patients that we can take from this and pass on to them is feeding infants safe forms of peanut and egg and from 3 months of age is safe and beneficial, and that we really can't advise much about emollients as a preventative measure for food allergy or eczema. So based on sort of some of these studies that we've talked about, in particular the LEAP study, the guidelines for infant feeding and recommendations have been sort of revised really worldwide. But we have also seen some issues in sort of implementation and uptake by families and patients and even physicians. This is what the guidelines coming out of the LEAP study, the guidelines that were changed in terms of peanut allergy prevention. There are three addendum guidelines. So if an infant demonstrates severe eczema, egg allergy, or has both, the recommendation is to strongly consider evaluation with peanut-specific IgE, skin prick tests, and if necessary, an oral food challenge. And based on these test results, if it's possible, introduce peanut-containing foods, and to start this between 4 to 6 months of age. For an infant who has mild to moderate eczema, the recommendation is to introduce peanut-containing foods around 6 months of age, and testing is not necessarily needed. For an infant who has no eczema or egg allergy or any other food allergy, you can introduce peanut-containing foods, but sort of when you want or when the family prefers and based on cultural practices. And you're probably familiar with the guidelines that give us actually very nice instructions for peanut introduction. We use this all the time in our clinical practice to help our patients who are not doing food challenges, but who are introducing peanut at home, how to introduce peanut to infants in a safe form using either bamba or peanut butter or a peanut flour that's pureed or mixed into a texture that is not a choking hazard, obviously. So there's a handout or a tear out that you can actually just give your patients as almost like a little recipe. So based on those are the NIAID guidelines. There's a consensus approach to primary prevention of food allergy through nutrition, came through the Quad AI College and Canadian Society of Allergy and Clinical Immunology, and was published in 2020. And I'll sort of give you the highlights from it. From their review of data, they decided that there's strong evidence that early introduction of peanut and egg within the first year can prevent the development of food allergy to these respective foods. They suggested around 6 months, but not for 4 months, and to only use cooked forms of egg, so no raw egg. And screening for evidence of sensitization to peanut and or egg before the initial introduction is not required, but it may be a preference-sensitive care choice for some families. And home introduction is actually encouraged when you don't have a high risk of reaction. If screening is performed, the clinician should encourage considering offering all the infants who are sensitized an oral food challenge and determine whether they're tolerant based on that, rather than rely just on the sensitization skin test and blood tests alone. And with respect to other foods, milk, soy, wheat, tree nuts, sesame, fish, and shellfish, we do not have randomized controlled trials yet that suggest a benefit from early introduction of these foods, but there's no data to suggest that early introduction around 6 months is harmful. And there are some observations or data that suggest that intentionally delaying introduction of other allergenic foods may cause harm, may cause more food allergies to emerge. So sort of where we are with guidelines, obviously we would like more solid information, but there's actually been some studies of uptake of guidelines and uptake of the sort of changes in early introduction recommendations to see how this is going in pediatric practices and allergy practices among families taking care of children that might be at risk. So studies have looked at, so actually surveyed allergists and pediatricians. They've found that there's confusion over what is a high risk definition, and that is, I think that's reasonable. The classification of severe eczema seems to be subjective and leads to a lot of referrals to allergists for testing. And there may be extra testing for non-high risk infants, which puts an extra burden on the system. There are delays in screening. Most of the allergy testing, even though it's recommended between 4 and 6 months, is happening after 6 months of age. So often by waiting for testing, we're missing the 4 to 6 month window and possibly resulting in delayed introduction, which was the opposite of what we wanted to happen with this. Cost effectiveness analysis has shown that early introduction without pre-screening to prevent the egg and peanut allergy is the lowest cost to society. Obviously, sending patients for additional testing and procedures like food challenges is not free. There's also been, there are actually, other barriers that have been found in surveys of physicians. So Gupta et al. In 2020 surveyed pediatricians. Most of them were aware of the guidelines. 29% of them fully implemented them. 64% partially implemented the guidelines, in particular for peanut. And they found these barriers for parents had concerns for reactions. There was uncertainty in understanding and applying the guidelines, and the limit of not being able to access in-office supervised feedings, in particular in a pediatrician's office. Another study in 2020 of allergists, 97% were aware of the guidelines. A higher number were fully implementing, meaning providing the recommendations to parents, and a third of them were partially implementing the guidelines, and similarly found that there was concern for reactions in the parents and also in the allergists. They didn't see, there was lack of referrals. Some were not interested, and some just did not have enough clinic time to manage all the referrals. And the other issues, we do have limitation food challenges are very high resource requiring procedure, and there are a lot of allergists who are not willing to offer food challenges to infants who have positive testing despite these guidelines. In the EAT trial, they sort of looked at the EAT trial and why was the adherence so bad in this particular study? Not that it was terrible, but it was less than ideal. And they looked at what were factors in adherence and non-adherence. They found that factors for enrolling, preventing patients from enrolling in the study included older maternal age, non-white ethnicity, and lower maternal quality of life. In terms of non-adherence, and after being enrolled in the study, parents were reporting symptoms, IgE type symptoms with feeding, and difficulty with feeding. So these were this non-adherence is actually associated with later introduction of the allergenic foods. So their conclusion from this was, if early introduction of foods were to be considered a strategy to prevent food allergy, families of non-white ethnicity, those with older mothers, and those with infants with reported feeding difficulties or early onset eczema would benefit from support to promote early and sustained consumption. So this sort of feeds into our theme, which is like, how do we support and guide our patients? I think I will I'll kind of skip through this. You can just read this, sort of consensus guidelines that really are just suggesting and not delaying introduction, and starting multiple foods at once is fine. in order to make sure that the babies are getting exposures at a relatively relatively quick rate. Because if you're introducing a new food every month, you're going to end up having delayed introduction of some allergen, even if you start with peanut at 4 months. I thought I'd include this just because we do have a lot of families and even pediatricians who recommend these commercial early introduction products. And we'll say that I don't think they're necessarily bad. There are benefits and drawbacks to using these products. This kind of looks at what is good and what is good about the commercial products and what is good about the conventional, off shelf and pantry versions of foods. The commercial products, and there's a whole bunch of different ones out there. There are maybe some more that I didn't include here. They're more expensive, but they are convenient. Sometimes the vehicle or what's in the commercial product actually can be an allergen too. We don't have evidence for like what is a desired or perfect dose for early introduction, so we don't know if these foods are meeting any particular studied need or amount of protein for an allergen that would be preventative or beneficial in terms of introduction. And sort of, that's sort of the I guess the crux of the conventional foods. I don't, if you guys have any questions about them, we can talk about that later. I actually did have a case series that I wrote about of patients who actually had allergic reactions to the natural form of food, even though they had been tolerating commercial introduction products. And these were reactions to milk, egg, peanut, and tree nut. And our feelings was that the doses in the commercial products that these kids had used actually had too low of doses or too an unsubstantial amount of protein of those particular foods. As I said, most of these products haven't been subject to clinical trials, so we don't really know what the optimal dose is for early introduction of all these foods. There was one trial that showed that a specific product was tolerated well, but they did not measure efficacy. And every product that's out there differs with regard to the form of the food, the allergen, or the combination of allergen, and certainly the cost. And some of the costs can be prohibitive. One other, this study from Chapman's group looked at actually like what are the for peanut in some of these early introduction products, is there consistency in terms of the allergenic proteins? And they found that there were differences in these different particular products. And we really focus often on RH2, and so this sort of looks at the differences in the different particular peanut allergens in these different products, just to give you an idea that they're not standardized. So we need more standardization and quality control of these products. And so we have other prevention measures that are still under investigation. I'll just kind of run through these quickly. I have no idea what time it is. So skin barrier, we talked about the one study. There are still other studies looking at whether enhancement of the skin barrier may affect food allergy development. So I know we mentioned the Preventadol, which was barrier emollient cream plus food allergy introduction. So these are some studies that are looking at just whether the skin barrier emollient and treatment of eczema prevents food allergy that we don't have data from. But we do think that some food allergy sensitization occurs through the skin. So it's sort of given us this dual allergen exposure hypothesis, and you've probably seen this this picture, which I think was on the cover of Jackie in 2018 or one of the other years. So.
Amanda, I'm just interrupting for 1 sec. I think we're running a little short on time, so maybe if you just want to skim through this part.
Okay, so I'll just say diet diversity seems to be important for both the infants and also for moms who are pregnant. Exclusive breastfeeding, we don't have evidence that this is preventative for food allergy. There is no proven benefit of hypoallergenic infant formulas. These are the references for that. Maternal exclusion of allergens during pregnancy. We don't have evidence that this prevents atopic disease, including food allergy in infants. And there are some studies that are still going on that will hopefully give us more answers about that. Supplements like vitamin D do not have any proven benefit. Probiotics might prevent eczema, but they're inconclusive for food allergy. And that part of that is that there's a lot of variability in probiotics, and we need both standardization of probiotics and more randomized trials. So right now we don't have any evidence that these prevent food allergy. So these are the conclusions regarding other ways, other prevention techniques or ideas for prevention. And we still need more data. I'll just, how much time do we have? I'll just very quickly say we do have some approved new treatments for food allergy, including Palforzia, which is peanut OIT, and omalizumab, which is Xolair. And I guess I won't probably have too much time to go into all this, but this is sort of an idea of this is a clinical trial that led to the approval of Palforzia. Palforzia is peanut OIT that, and on the right side, you'll see these are the patients who did peanut OIT, how well they did in terms of tolerating peanut at a food challenge after a year of peanut treatment. And so we do have this available for 4 to 17-year-olds and more recently for 1 to 3-year-olds as a way to desensitize patients to peanut. And then omalizumab is a medication that was studied in the Outmatch clinical trial that was published 2 years ago. And omalizumab is an anti-IgE. It's a biologic given by injection, and basically omalizumab increases the threshold for reaction to a particular food. It's not food specific. Everybody in this particular clinical trial was peanut allergic and demonstrated improvement in their ability to tolerate peanut at a food challenge after 16 weeks of omalizumab, going from less than a third of a peanut up to 2 peanuts or a gram of peanut, and also trending towards improvement for other foods as well. So this was approved in 2024 for anyone over 1, and we have many other things that I didn't really talk about, but would be a subject of another Viaskin, which is a peanut patch. There are other biologics that we're looking at. There's a peanut virus-like particle that is sort of like a vaccine that's being looked at. So there are many more things on the horizon for patients with food allergy, but we don't really have time to get into that. I'll let Allie take it away from here.
Thanks, Amanda. Okay, so breaking it down, kind of taking all the evidence and thinking about what is relevant or practical for nurses, especially in patient education. So the big takeaway is early introduction can help prevent peanut and possibly egg allergy, which I think probably all of us know that by now. It's really important to just reinforce all of this teaching during food challenges or OIT appointments or however you interact with patients, encouraging regular feeding, not restricting, encouraging early introduction. And then something that we're seeing a lot in our clinic is with all these great, amazing new treatments comes also a lot of complexity and shared decision making that needs to happen. And then, of course, if you're actually clinically giving the food, whether it's a food challenge or OIT, nurses are, on the front line of looking out for a reaction and treating a reaction. In terms of prevention, reinforcing early introduction messaging is kind of the most important. Something that we try to do in our food challenges, if an infant is there for one food challenge, we often will look at the note from the physician from the last follow-up visit to see what else the doctor recommended for introduction. I would say 50% of the time when we do this, the parents have not introduced the recommended foods, mostly because of either anxiety or they didn't read the instructions. So I think a food challenge is a really great time to think about the other foods, not just the food that you're challenging, but to just reinforce early introduction and address the anxiety and do that teaching. We also give a lot of feeding resources. We have our amazing dietitian, one of them who's on this presentation. So we have a lot of resources, especially for picky eating, ways to keep it in the diet. So we do a lot of care coordination that way. Okay, next, please.
Okay.
And then just in general, practical tips recommending peanut and egg introduction between 4 and 6 months. We do a lot of teaching also about infant safe forms. So the guidelines that Amanda showed you, we print those out. We talk a lot about, pureeing a scrambled egg if that's what you need to do to get an infant to eat it. We want to encourage keeping the introduced foods in the diet. We get a lot of questions about younger siblings. So all the time, the families will say, "Oh, I just had a baby and they have eczema. What do we do?" So I think that's another great way to kind of reinforce the evidence that we have, and then encouraging families not to delay complementary foods. As we all know, many parents are still scared of allergic reactions. I think providing reassurance and clear instructions that helps, or even just empathizing with the anxiety and reassuring families can help a lot. Empowering them to feel like they know what to do if they do see signs of reaction. We get so many families who worry that, their 4-month-old is going to have anaphylaxis from a lick of peanut butter, and we know that that is very, very unlikely. How many times have we heard of parents going to the hospital parking lot to give their baby peanut for the first time, which is not what we recommend. So just reinforcing all of that, trying to give more confidence to families, educating them, empathy, that's a huge part of it. I try to usually tell the parents, like if they're very anxious to introduce these foods, say it's a short-term, high anxiety period to introduce a food, but the alternative could be a long-term food allergy. So I kind of try to frame it like they just have to get over that hump of the initial anxiety. And then, like Amanda talked about, it's great that we have so many new therapies, but there's a lot of nuance to it. And I think, especially if you're a nurse doing food challenges and you're spending 4 hours with the patient, you can really get a lot of helpful information. Is the kid a picky eater? How anxious is the parent? Is this 18-year-old with a peanut allergy who's never had a reaction before? Does that patient really need Xolair? He seems very well adjusted and not anxious in the 4 hours you meet him. So I think nursing can provide a really good view into the family situation as we are, deciding which therapy is the best for each patient. And I think that's it.
What is
Thank
it?
you so much. All right, so we are going to open up for questions. Actually, just to let those who joined a little bit later, we do offer receives for the session today. You're welcome to put questions in the chat and also unmute, raise your hand and ask. We'll take a few minutes for questions. All right.
Just making, there's no questions in the chat, are there? Okay. I was just making
Not
sure.
yet, but somebody
Okay.
raised their hand. Karen, go ahead.
Sorry, y'all. I just got home, so I apologize if I sound rushed. Great presentation. I think a lot of the points that were raised about anxiety, especially with the introduction of peanuts, is kind of like happening a lot. I work in both primary care and in the pulmonology department. The pulmonologist I work with does have the allergy board cert too. He has about a 4-month wait period for referrals for allergy, specifically like oral food challenges. So we're getting a huge influx of infants who may or may have not been exposed to peanut debris. So the most latest one I saw was the peanut curry potentially. They had vomiting and then some facial swelling, lip swelling. So I had told the NP to prescribe the EpiPen because there was a high suspicion for the peanut. But in those cases, he tends to lean more of like, let's just wait and watch. We don't need to do a food challenge now. Potentially when they enter daycare or a place that there could be some exposure of that peanut, then we could do the food allergy challenge or figure out our options. We do blood testing with the peanut component on Quest, but what would you say? I heard you like nursing staff is really empowered to do that oral food challenge. So I'm just curious on your experience how to tackle this part because I just feel like we're getting a lot of mixed messages to the parents, and I'm trying to standardize the care at our clinic. But
Yeah.
any insights on that?
So in our clinic, all of the food challenges have to be offered by the physician. So the nurses are not the ones deciding who is eligible for a food challenge. But a lot of times families may be nervous, even once a food challenge is offered, they may not want to come in because they're just too anxious. So if a family is coming in for a lower risk food, that's a really good time for nursing to kind of help build confidence, talk about fears, or talk about preparing for a higher risk challenge to kind of get that uptake in the challenge. But in terms of who's offering the challenge in our clinic, and I think probably in most clinics, it's the doctor or the nurse practitioner. But we always, if we think a patient has at least a 50% chance, especially an infant with peanut, we always offer the food challenge and we expedite it so those patients get pushed to the very top of the list. There is still a wait. Even the very top of the list, there is still a wait, but we always, unless we are convinced the baby is absolutely going to react, we pretty much try to get them in.
But yeah, we do feel that like pressure and we wish we could do more and offer more. We're just, we're limited. Um, we're limited to how quickly we can do those food challenges. And also it takes a long time to just get the consultation appointment. So by the time a baby who's had a reaction, between 4 and 6 months of age gets to see us, they're probably 8 or 9 months now, and then we do the testing, and then we'll refer them for future. I know that the sensitization is getting, for some infants, is getting worse during that time, and they may need treatment, so we'll put them into OIT as early as we can. But there is no question that there's a shortage of allergy testing, and it's not necessarily allergy testing, but food challenge options for everyone. And if we're in New York where we're not the only ones doing food challenges, but if you look the whole city, it's a long wait. And I know that other like big centers have long waits too. We're doing what we can. I think the idea of like a patient who's low risk doesn't have an egg allergy or positive peanut skin test or reaction history, like they should be introducing early, and they don't necessarily need testing for peanut. But otherwise, there's certainly a shortage of food challenge slots, like probably nationwide. So I feel the urgency that you feel.
Thank you all.
And Ali, you mentioned also the parental anxiety. I just put in a chat the new resource that was published recently may contain anxiety by Tamara Hubbard, who's actually works with this patient population and has personal professional experience with anxiety related to food allergies. So I guess that's helpful to your patient population and caregivers. I think that might be a good resource to offer. Any other questions for our speakers? Jessica?
If I could, yeah. Dr. Cox, thank you so much. It's always great to get to meet with you. And Allie, thank you. Olga, also for amazing speakers every single month. My question for Allie is about baked egg, baked milk. If you have any strategies for that, since that's often the go-to for doctors to introduce young, but of course that texture is pretty rough for 4 to 6 months old. So any tips around that would be awesome. And then Dr. Cox, I would love to hear if you are doing some early food challenges on kids that have been on Xolair for a while, and where are you finding your guidelines? You're probably creating them for sort of the threshold levels that you're using in those challenges.
Great question. Well, I'll answer the easy one. For baked egg and baked milk, we recently started in our standardized instructions, we started telling parents to puree one muffin with water or milk or breast milk and bring that in addition to the whole muffins. And then we just measure by weight. So we weigh the whole puree and then, take 1/16 or 1/8 of that amount as the first dose and kind of do a similar progression. I've also just used a mortar and pestle and mashed it up and mixed it with a puree that the baby likes. It's one of the harder ones to do because it's also such a big volume. I will say our dietitians have also kind of given us the green light a little bit to go lower on the dosing for babies because realistically, a baby should not be eating a half a muffin, like a five, I mean, not a 5 month old, but like we usually will do baked egg around like 8 months, right, Amanda? Like that's probably the
Yeah, I think, yeah.
earliest with the texture. An 8 month old baby should not be eating half a muffin anyway. So we've kind of, I would say, in the past few years, gone towards, okay, if they're only eating a quarter or sometimes even a little bit less, depending on the size of the baby and their eating habits, we'll pass them for that amount. And then just as they get older, they will eventually start eating a bigger amount at home. But it's tough. Oh,
And then,
also one other thing, we've started telling families to practice with a vegan muffin, and I think that has really helped too. We usually recommend the Abe's ones, so just getting used to that texture and practicing can help.
yeah, so I would say I would concur that if we see the baby before they're eating that texture, we want them to practice before the food challenge with the texture. If it's like an 11, 12 month old, and we expect they could handle it, but they just haven't had anything baked before. So we like them to practice. And then your question about Zolar, we don't really have guidelines yet for when to challenge. We have, I see Jamie here, who's our outmatch, our research coordinator for that study, and the main nurse involved in that are outmatched patients. But so for Xolair, we're actually considering starting low threshold challenges at around a year after being on Xolair. We're looking at probably doing between 600 and a gram of protein to see if the threshold has improved for patients. And I think it's a mix. There are patients who are already asking for this. They would like to know if Xolair has improved their tolerance or how much they can eat. If they really should, because they don't know if they should feel comfortable being able to eat in the world and have things with trace amounts or low, like higher likelihood of cross-contamination foods. So we are looking at that. We haven't really started doing it except for maybe a few patients, but we're at the point where we're probably going to start doing it, and we'll actually be studying it as well. So I don't have guidelines for you. We don't have guidelines yet either, and we're still trying to work it out and see what's best for patients. I think some patients will not want to know, and they'll be fine just staying on Xolair, and others will want to see if there is an improvement.
Thank
But
you.
I think somewhere around 600 to 1,000 milligrams, similar to the Outmatch study, would be like a reasonable place to start.
Susan, I know
Great, thank you.
Yeah, hi. I just have a quick question. That was excellent. Thanks so much. I work in primary care pediatrics, and I am often called into the room to help families with all kinds of food allergy related questions. One of them is when the kids have like eczema on their cheeks, and they're starting solid foods. I was interested in the studies that you said about the skin barrier and things. So do you recommend covering the area with Aquaphor or something before feeding them, or is that really negligible based on the research?
I think, and Alec, you can step in too, because we do put a lot of Aquaphor or barrier cream on our patients when we're doing food challenges, in particular if we know that these kids tend to get redness or flare their eczema with any kind of food or acidic foods and sort of even non-allergens. So sometimes we will do that. I don't think we're looking at it as a way to prevent the food allergy, but more of a way to prevent like the irritation that could occur and then make you think, oh, this kid's having a reaction. So
Okay.
that's our thinking about that. But we do recommend and have a lot of our patients do that, but just mainly to prevent the irritation or the eczema flare that can happen with almost any food that's introduced, and especially the infants that start feeding themselves at 9, 10 months, and it's a mess, it's everywhere, and it sticks there for a while you give them an hour to eat their dinner. So that is something that, we'll even have our patients do if they're noticing it's a problem. But I don't think we're looking at it as that's going to prevent the food allergy.
Yeah.
Okay.
We with infants and toddlers, it's one of our like basically standard questions before we start feeding is we ask, oh, do they get red around the mouth even when they're eating foods they already tolerate? And if the answer is, oh, only with tomatoes or something, no. But if it's basically anything else, we just throw on A&D ointment in the food challenge. But yeah, it's just kind of like an in the moment thing. It's not to prevent a long-term development of an
Yeah.
allergy.
And I mean, there may be, if patients are nervous, and they're starting peanut or egg, which we do see contact reactions to those foods sometimes. Especially egg, we see contact reactions to egg that actually sometimes isn't even an allergy, but some kids develop hives with egg or milk. A lot of foods can actually just cause contact hives. So for those kids, we'd also suggest it just if you're especially if you're starting a new allergen, mainly so you don't freak out that there's a hive in there.
And in the food challenges for the leaps, we often try to feed the babies with a PO syringe with the peanut butter mixed with water. And then if they take a pacifier, we encourage the pacifier right after. So just, anything to minimize the contact.
Thank you. And I see Darren's hand is up, and I know it'll probably be the last question because we're out of time.
Oh, yeah, it was just saying that protecting the face with the greasy or thick cream, it helps the parents not be so anxious because they're hyper vigilant for the slightest change of that skin, and then they freak out. So that protecting, apart from the fact that you're protecting with the barrier, and if we all sat with the same food on our face, it would react as well. But you're dampening down that hypervigilance and overreactivity to the slightest change, which could be that the child's a bit warm in the room.
Yeah. Sometimes I'll tell parents who are anxious about that, I'll say if you put the food on their skin, it's the same as doing a skin test. And almost all of our patients have a positive skin test coming into the challenge. So I think it helps to explain it that way too.
Thank you. Thank you so much. I'm going to stop the recording.